freaking 309. Oh my god. Go. Oh my god. I don't know if you can see it. Just turn on. Alright, so it's motherfucking 3:10. You can see that. I'm like dead awake since 2 a.m. Just laying in bed. Felt like sharing if anyone else has insomnia. Cause yeah. Also, here's a really, I don't know if you can see this, but I kicked this toenail and it freaking came all the way off and he's like barely hanging on and it really hurts, but there's your update. I'm just gonna sit here and probably drink water. I was thinking about making a ring because I need to replace this one. He's getting a little old, but yeah, it's because I didn't take my sleep meds and I was like, oh, I'll be fine. One night's fine. Take your fucking sleep meds because now I'm up and I don't want to waste them because it's 3 in the morning and I don't want to like sleep fucking all day, so. I probably had too much water in too short of a time frame since I woke up, chugged half of it, attempted to sleep, could not sleep, drank the rest of my water, filled up my water, and drinking more water. Boy, ADHD, your brain just goes. When I was in high school, I would draw my old cat, Sticky. It was, I mean, they weren't the best drawings because I wasn't the greatest at art yet, and I wouldn't say I'm the greatest at art either, but or crochet or do something, but yeah, that's just the vibe. I don't know. I'll just throw this into whatever. So if anyone can relate to having insomnia, bro, leave it down below. Cause we're just sitting here in the bathroom. Wet wipes, cause Eli poop a lot. There's a water heater. I'm sitting on the toilet. It's the vibe. I don't know, I don't have much more, and I'm probably just gonna sit here for like till I can sleep again, but Alright, shorts. Welcome back to another episode of Can We Lift It? Where your answers vary depending on whether or not it's yes or no, if that makes sense. Struggling to get this on. We're cranking some back today. Put on the hooks because this is just my personal opinion, but they kind of feel, I think, Jesus fucking Christ, hooks feel better on a back movement. I don't really know why, because I don't know. To be honest, I don't know. It's probably because these end up sliding down and it's really just my wrist holding on and I don't have to use my hands at all, but I'll take it. I think we're just going to throw a plate on and see if it wants to move or not. Because I think that's the best way to do this. Shorty's also throwing the belt on because I can't. Bitch. That was low-key kind of ugly. I say, we try underhand. Maybe that's why it sucked, because it was overhand. Who knows? Could be different. It says the overhand row is more for the upper back, teres major / minor, rear delts, rhomboids, etc., while the underhand grip is more for the lats and lower lats and imaginary biceps. Try an underhand. All right, let's see if this is a little bit less ugly. Where's the freaking grip? Where's the grip all along? So, 2 birds, 1 stone. I've constantly an hour and 50 minutes. And I figured I should probably go over my algorithms. And that's actually a thing I used to do. Was between my sets, I just sit and memorize my things. But I'll share some knowledge with you so we can study and wait our 2 minutes in peace. Hold on. VFib. Pulseless VTAC. Assess patient, unresponsive pulseless synaptic. Initiate CPR. Give oxygen. Apply monitor / defibrillator. Charge, clear, rhythm analysis. Defibrillate 120 to 200 joules biphasic. 360 joules monophasic. CPR 2 minutes. Start IVIO and administer epinephrine 1 milligram IVIO, 2 milligrams ET if IV not available. Repeat Q 3 to 5 minutes for entire resuscitation. Charge, clear, rhythm analysis. Defibrillate equivalent or consider higher dose. CPR 2 minutes. Secure airway with end-tidal CO2. Amiodarone 300 milligrams IVIO. Repeat 150 milligrams IVIO after 3 to 5 minutes. Or lidocaine 1 to 1.5 milligrams per kilogram IVIO. 2 to 3 ET if no IV. Repeat half original dose. Q 5 to 10 minutes up to 3 milligrams per kilogram. Charge, clear, rhythm analysis, defibrillate equivalent or consider higher dose. CPR 2 minutes. Continue CPR, defib drug cycles. Treat reversible causes 5 H's, 5 T's. Hypovolemia, hypoxia, hydrogen ion acidosis, hyperelectrolyte, hypothermia. Toxins, overdose, tamponade, cardiac, tension, pneumo, thrombosis, coronary, thrombosis, pulmonary. Cool. Okay, that one was a little iffy. I'm thinking we should probably just stick with the 45s. I'm a little bit jealous of sometimes. Like the guys, I can just jump from like a plate and like I'll go up and wait, so I throw on another plate. Like, bro. One day, that'll be me. That's just not today. Maybe tomorrow. Oh my god. Okay. Those are better. And I still think they could probably be a little bit better. Asystole, pulseless electrical activity, PEA. Assess patient unresponsive, apnea, pulseless, apply, monitor / defibrillator. Trauma, transport. Confirm asystole in more than one lead. If rhythm is possible, VF. Go to VF algorithm. Is there any evidence? Resuscitation should not be attempted. CPR 2 minutes. Oxygen. Start IVIO. Administer epinephrine ASAP. 1 milligram IVIO, 2 milligrams ET if IV available. Repeat Q 5, 3 to 5 minutes for entire resuscitation. Reassess CPR. Secure airway with end-tidal CO2. Treat reversible causes, 5 H's, 5 T's. Hypovolemia, hypoxia. I think hypoglycemia is PEDS. Hypovolemia, hypoxia, hydrogen ion acidosis, hyperelectrolyte, hypothermia. Toxins, OD, tamponade, toxins, OD, tamponade, cardiac tension, pneumo, thrombosis coronary, thrombosis pulmonary. We're getting there. Oh, shit. Oh, shit. I actually think it'd be a little bit easier to move if I put her down a peg. Maybe not. I don't know. I just work here. We're cranking through this. All right. Immediate post-cardiac arrest care. Return of spontaneous circulation. ROSC. Optimize ventilation and oxygenation. Maintain SpO2 between 92% and 98%. Consider advanced airway and waveform capnography. End-tidal CO2 between 35 and 45 millimeters of mercury. Do not hyperventilate. 10 to 12 breaths per minute. Treat hypotension. Go to hypotension algorithm. Consider reversible causes. 5 H's, 5 T's. Hypoxia, hypovolemia, hypothermia, hydrogen ion acidosis, hyperelectrolyte. Toxins, OD, tamponade, cardiac tension, pneumo, thrombosis coronary, thrombosis pulmonary, and then a 12 lead ECG in hospital only. This part, I'm not really sure. A patient following commands, consider coronary perfusion or other advanced critical care. If patient not following commands, consider induced hypothermia at 32 to 36 degrees Celsius for at least 24 hours. Oh, guys, we're getting through this. Look at us go. So we're doing pretty okay on time. Acute coronary syndrome. Goals for AMI treatment. Alleviation of pain and apprehension. Prevention and management of dysrhythmias. Limitation of the infarct size. Time is muscle. Triage and notification of appropriate facility. Secure airway. Administer oxygen. If dyspneic has heart failure or SpO2 less than 90%, administer aspirin, PO 160 to 325 milligrams. Start IV, obtain 12 lead ECG, notify and transport to appropriate facility in the STEMI system of care. Consider nitroglycerin 0.4 milligrams, sublingual paste or spray if BP is greater than 90 millimeters of mercury. Repeat Q 5 minutes to 3 doses. For angina unresponsive to nitrates, consider opiates. Morphine 2 to 4 milligrams, slow IV push. Q 5 minutes. 12 lead ECG, STEMI, ST elevation, or new left bundle branch. High risk. 12 lead ECG triage, unstable angina / MSTEMI, ST depression, or T wave inversion. High risk. 12 lead ECG triage, non-diagnostic ECG, or normal ECG. Low intermediate risk. One more. I get one more here. Let me know. I think I'm freaking cool on that. I want to go hit some lat pull downs, but on the other one, I don't know. I kind of want to wrap my hands around the bar. Maybe I should use hooks on it. We'll see. So what if we try hooking in on the bar instead? Maybe I'll enjoy it more. I'm not vibing. I'm gonna go to the other one. Get it this way. Oh yeah. Look at that. That's beautiful. That's art. And I'm wearing switch the straps. Because I got strapped around this bad boy. I'm sure I could have done fine if I switched the straps on that, but I don't know. It's something in my left shoulder. It just don't like it. Because deep down there's probably an actual injury down there that I'm gonna ignore. Symptomatic bradycardia. Assess patient, ABCs, vital signs, history, exam, monitor, oximeter, identify and treat underlying causes. Persistent bradyarrhythmia causing hypertension, BP less than 90, altered mental status, chest pain, CHF, seizures, syncope, or other signs of shock. Primary focus, support airway and breathing. Administer oxygen, rule out hypoxia. Start IVIO, 12 lead ECG, do not delay treatment. Administer atropine, 1 milligram IV, 1 milligram ET if IV unavailable. May repeat every 3 to 5 minutes, up to 3 milligrams. Use with caution for second degree, type 2, or third degree heart blocks. If atropine ineffective, consider TCP, transcutaneous pacing, and or dopamine infusion, 5 to 20 micrograms per kilogram per minute, alone or with epi, or epinephrine infusion, 2 to 10 micrograms per minute, alone or with dopamine. How many pages do I have left? 1, 2, 3, 4. Cool. Q. Oops, shit. Sometimes in life you have to spot yourself. That was a really weird feeling. It's kind of cool though. Tachycardia with pulses. Assess patients ABC vital signs monitor. Or ABC's vital signs history exam monitor oximeter. Sinus tachycardia treatment focus on the underlying cause. Secure airway. Administer oxygen. Rule out hypoxia. Start IV. Treat reversible causes. 5 H's, 5 T's. Hypothermia. Hypoxia. Hypovolemia. Hydrogen ion acidosis. Hypohyperelectrolyte. Toxins, OD, tamponade, cardiac tension, pneumo, thrombosis coronary, thrombosis pulmonary. Persistent tachyarrhythmia causing hypotension, BP less than 90. Altered mental status, chest pain, CHF, severe syncope, or other signs of shock. If yes, synchronized cardioversion. Consider sedation, diazepam 5 to 10 milligrams IV, or diazepam 1 to 2 milligrams IV or Versed 1 to 2.5 milligrams IV, and cardiovert. Consider adenosine 6 milligrams, rapid IV, can repeat at 12 milligrams if needed. SVT 50 to 100, 200, 300, 360. VT 100, 200, 300, 360. AFib 120 to 200 triphasic, 200 joules monophasic, 300, 360. If no, 12 lead ECG, QRS is less than 0.12 and regular. SVT equal to a rate greater than 150, rhythm regular, no P waves visible. Attempt vagal maneuvers, adenosine 6 milligrams rapid IV, can repeat at 12 milligrams if needed. If rhythm is irregular, lucid, or does not convert, transport. QRS greater than 0.12 and regular, PTAC or SVT with apparent conduction. Adenosine 6 milligrams rapid IV, can repeat at 12 milligrams if needed. Amiodarone 150 milligrams IVIO over 10 minutes. Repeat as in up to 2.2 grams in 24 hours. Consider elective cardioversion if rhythm is irregular, Trossard's, amiodarone, magnesium sulfate. Where is my water? Ventricular assist device. Assess patient, ABC, vital signs, history exam, monitor, oximeter. Secure airway. Administer oxygen, rule out hypoxia, or assess ventilations if indicated. Assess and treat underlying causes. Glucose overdose or stroke. Assess skin color, temperature. Assess capillary refill. Inadequate perfusion. Assess LVAD function. Listen for alarms. Listen for LVAD hum. LVAD malfunctioning. Attempt to restart LVAD. Driveline connected. Power source connected. Replace system controller. LVAD did not restart. Begin external chest compressions. LVAD restarted. Continue assessment. LVAD functioning. Assess MAP and end-tidal CO2. A map of less than 50 millimeters of mercury or end-tidal less than 20 millimeters of mercury. Perform external chest compressions. Map above 50 or end-tidal above 20. Do not perform external chest compressions. Okay, hypertension / shock, acute pulmonary edema. Assess patient, ABC's vital signs, history, exam, monitor, oximeter. Secure airway, administer oxygen, rule out hypoxia. Start IV treatment. Or treatment is focused on the underlying cause. Volume loss, stop the event. lactated ringers, normal saline, 250 to 500 milliliter bolus. Repeat till BP 90. Abnormal rate, less than 60 per minute or greater than 150 per minute. Go to Brady or Techie. Algorithm, cardiogenic shock. BP less than 90, consider LRNS 250 to 500 milliliter bolus. Dopamine 5 to 20 micrograms per kilogram per minute, or epinephrine 2 to 10 micrograms per minute, or norepi 0.1 to 0.5 micrograms per kilogram per minute. Acute pulmonary edema, oxygen to SpO2 greater than 97%, nitroglycerin 0.4 milligrams of BP equals 90, repeat Q 5 minutes, up to 3 doses, or NitroDrip. CPAP and consider morphine 2 to 4 milligrams slow IV push every 5 minutes until pain is relieved. Furosemide basics 0.5 to 1.0 milligrams per kilogram IV. One more after this, guys. I got like another set of me. Oh, shit. 8 hours of me reading paramedic algorithms for you to go to sleep too. Hypothermia. Last one. Assess patient, ABCs, vital signs, history, exam, monitor, incident. Oh shit. I got one here. Look for J-wave or other rhythm disturbances. Secure airway, administer oxygen, rule out hypoxia, start warm IV. Pulse present? Question mark. Temp greater than 32 degrees Celsius. Mild external rewarming, hot packs, blankets. Temp less than 30 degrees Celsius. Severe internal rewarming, warm IV fluids. O2. Pulse absent. Defib, VF, and VT. 120 to 200 joules biphasic, 360 joules monophasic. Temp greater than 32 degrees Celsius. Continue CPR, meds, and defib. Prolonged intervals. Temp less than 32 degrees Celsius. Continue only CPR, rewarming, no med or defib. And that's it. Cool. Crank this shit up. Alright, shirts. That's all you get. Otherwise, I'm gonna go blow up the fucking biceps.